So March 28th, 2014, I had my second double lung transplant, and despite everybody's concerns, it was actually much easier for me the second time than the first. I was out of the hospital in less than 2 weeks, and as you can see, I'm coming up on my 10-year anniversary post-second double, so I've been very, very fortunate. And unlike the first time I knew exactly what I wanted to be when I grew up, I actually figured it out in ICU. I decided that when I got out of the hospital, I wanted to help other patients and families that were navigating this healthcare system of ours, because sometimes it really does feel like you have to have a medical degree to be able to be a patient. And so I thought maybe I could do something to help people who were struggling to get through our complicated systems. So there's a funny thing that happens when you have two major medical interventions, like 2 double lung transplants. People like to ask me things like, have you jumped out of an airplane yet? Because in our culture, we believe that when we want someone to prove they're grateful for their life, they should put their life in jeopardy. Makes sense, right? But I'm way too wimpy to jump out of an airplane. But when I was in Kitty Hawk, North Carolina, I saw people jumping off of sand dunes with hang gliders, and I thought, oh, perfect, I can prove I'm grateful for my life, finally, right? So there I am, strapped into the hang glider. I'm literally hyperventilating. Eventually I get up, and I stand, and I run, and I jump, and I fly, and I land, and guess what I find out? I really don't like jumping off of stuff. That's pretty much what I found out. So I'm hoping there's other ways that I can prove that I'm grateful for my life besides jumping off of high places. I have gone on and had a very exciting career that's now landed me at Duke Hospital. I have gone into the kennel and adopted some beautiful dogs. Up there is Jenny. She was an Irish racing greyhound. So she drank a lot of Guinness, and she had a very thick accent. And then there's Emily, and she is a whippet. And I guess one of the wonderful things, I don't know what the right word is for that, but one of the things about being a recipient like myself that gets to live as long as I do is I get to be around for the fun stuff, and I get to be around for some of the sadder stuff. So I've been here for these girls when they went on and went to the other side. And I have fallen in love again. That's Daisy. She's also a whippet. I don't know if you guys have noticed this yet, but I like dogs that look like aliens. It's pretty much my MO. So I fell in love with Daisy, and then I fell in love with Professor Pickles, and then I fell in love with Gabby, the Border Collie, and then I fell in love with Sydney, the Greyhound. So I'm officially now the crazy dog lady, and I'm super excited about that. I love having a pack. It's really fun. And most importantly, of course, is that I still get to be a sister, and I still get to be a daughter, and I still get to be a friend, and you know all those cliches that we say about end of life, they're true. That's why we say them, that's why they're cliches. When you get to the end of your days, this is what you're thinking about. The people in your life, how much you love them, whether or not they know how much they mean to you. And so one of my goals became to tell people, not wait until I'm on my deathbed for the 3rd time, but to actually just go ahead and say it when I was thinking it or feeling it. And the surprising part about that goal is how hard it actually is to do that. But it's still a goal I have. And I'm still working on that other thing. So I'll let you know how that goes, but I'm not going to talk about that anymore. So shifting gears a little bit, we're going to start talking about partnership. So for me, at the end of it all, when you boil patient and family-centered care down to its roots, we're talking about partnership, right? So I want to talk a little bit about what patient family-centered care is and what it's not. So what patient family-centered care is not, it's not a bedside manner, it's not being nice. That's not to say that we don't want our providers to be nice or have a good bedside manner. But when we're talking about patient family-centered care, this is not what we're talking about. We're not talking about a concierge service, although I love it when you make my towel into a duck. That is not patient family-centered care, right? And most importantly, it is not an absence of boundaries. And this is where a lot of us in healthcare have started to become a little confused. Just where are those boundaries? Putting up boundaries is a part of patient and family-centered care because we have to take care of ourselves. We have to take care of patients that are in the room next to the patient, right? So boundaries are absolutely an appropriate and essential part of patient and family-centered care. So what is it? Well, we of course have to consider the patient experience. We have to encourage that culture where everybody cares. And then we have to actually hear it from the horse's mouth. I have been to plenty of staff meetings, as I know you have as well, where we talk about the patient experience and there's not a patient in the room. And this is where our culture is shifting. We have to bring the patients and the families to the table to actually hear what that experience is and design the protocols and the guidelines around them. And so that's what patient-family-centered care actually is. It's action. It's listening, taking that feedback, and based on that feedback, making change. That's patient and family-centered care. So, we all know that we get feedback in a lot of different ways, and that feedback can be applied to individual behavior, it can be applied to policy, IT, I'm sure you can think of plenty of other places. So, improving the patient experience, as I've said, allows us, or it really requires us to bring patients and families to the table. So I know you all have a Patient-Family Advisory Council. I want to just speak briefly about the Patient-Family Advisory Council we have at Duke. I happen to be pretty proud of it. It started in 2005, and we have our patients and families involved in many, many areas of our health system. We have them presenting their stories at staff orientation. Every staff orientation, we have a patient-family speaker. They are on committees throughout our health system about various topics. Of course, in-staff, grand rounds, things like that. We have 10 Team Steps Master Trainers that are patient-family advisors, so that's a unique thing that we have. We have created our own advanced care planning videos to educate other patients and families on the need to complete their advanced directives. So those are just some of the things that we're doing. I just want to mention some of the lessons that we've learned, and then I'll move on from this topic. One of the most important things that we've learned for creating successful patient advisory councils is an extensive interview process. It's not about how many people are on the council, it's about the quality of the people that are on the council. So we are kind of picky, and it's not uncommon for us to say thanks, but no thanks, you're not the right fit. We have a 3-hour required training for all staff and all patient and family advisors. So this allows us all to be working out of the same playbook and make sure the right hand and the left hand know that what they're doing. We have wonderful leadership, participation and support, which I think is very essential, and we all work within that spirit of partnership. So there's not one patient or family member that's in that room that has an axe to grind. This is all about making sure that we work together to improve the experience of everyone. So that is our final guiding principle, which is collaboration. So one of the collaborative efforts that came out of our Patient Family Advisory Council is around safety, and that's what I'm going to talk to you about for a little bit. So those of you who are familiar with Team Steps, bear with me. And how many people here are either Team Steps Master Trainers or have been to a Team Steps Essentials class? Okay, so let me talk a little bit about what Team Steps is. I'm sorry, I'm going to be annoying, and I'm going to just read it off the slide because that's the best way to do it. So it's evidence-based teamwork system to improve communication and teamwork skills. It is based on the aviation model of safety. So when that study came out that 44,000 to 98,000 people die every year due to medication error, our government's response to that statistic or to that study was to create Team Steps. And what they did was they went into the world of aviation and they took all of these safety tools that had already been tried and true in the world of aviation and they applied them to medicine. And that's what Team Steps is. So it's rooted in 20 years of research. It was developed by the Department of Defense. It clarifies team roles and responsibilities. We hope, and it works towards resolving conflict, improving information sharing, which you might remember is one of our guiding principles, and it eliminates barriers to quality and safety. So one example of that is the whole idea around anyone in the room should be able to speak up, right? So if you have a surgeon, he may be the best surgeon in the whole world, and if he's about to cut on the wrong leg, there should be anybody in that room who feels empowered to speak up in that situation. So that's just kind of an example of what Team Steps is going for. So, I love Team Steps. I'm a Team Steps Master Trainer. I'm a huge fan of Team Steps. And there's one big piece of Team Steps that they haven't quite perfected yet, which is that the patient is not yet a part of that team in Team Steps. So we're changing that. We're changing that. And we're actually have had a forum at Duke to look at what tools from Team Steps can we use to apply to partnership strategies. And guess how many of them we found that we could use? All of them. There was not one tool that was not usable for provider to patient and family. So, as we all know, having the patient and family be a part of our healthcare team is a popular ideal. But would you agree with me when I say I think we still have a ways to go to figure out what exactly we mean when we say that, right? And so the beauty of these Team Steps tools is that it's this ripe fruit that's ready to be plucked and used. So we're going to talk about 3 tools, but first I want to just mention the fact, well, one thing I love about this slide is that it's already out of date. I created it, maybe a couple years ago. It's already out of date. Originally, I wrote that we have to give our patients and families permission to participate in their care, and that is no longer PC. Why can we not say that we ask or give our patients and families permission to participate? Why is that not good language? Right. It's their body, right? It's like saying you have a right to talk about your body, right? So, but what we do need to do is invite. We do need to invite patients and families to participate in care. Why do you think that I might say that? What's the importance of the invitation? They will feel welcomed, right? Because that's a shift. It's not the old model. So we have to invite so that we can talk about the fact that things are changing, right? Why else might we need to invite?
They have control of the decision.
Exactly, they have control of the decision. Not everybody's going to want to participate in the same way at the same level. So that's the first question I need to know, is how involved and in what way do you want to be involved in your care? So that's part of that invitation. One more reason, you think, why we need to invite? It's safe for them to speak up, absolutely. As a patient advocate, and I'm sure all of you are also aware of this, unfortunately, our patient population still has this fear of retribution. It's not uncommon for me to go into a room, take a complaint, and then have that patient say, you know what, I changed my mind. I really don't want you telling my physician all of this because I'm afraid that will change the way that they take care of me, right? So we talk about the culture shifting. But when we say that, we're usually talking about the culture of providers and staff. We also need to start thinking about the culture of patients and families shifting, so that fear of retribution can go away and we can really, truly become partners. So we say, please, be a part of the team. Please speak up. That is wonderful. And what does that mean, right? If you say to somebody, we really want you to speak up, what does that mean? Well, that's probably going to mean something different to everybody, right? To some people, it'll be like, oh, goody, now every time I have a question, a comment, or I just want to chat, I'm going to call my nurse, right? That's not really what we're talking about. And conversely, there are the other people that usually patient advocates work with who say, oh, okay, I'll speak up. I'll take an internal inventory of absolutely everything that I think did not go very well during this admission, and I will at some point explode it all over you, right? That's not what we mean when we say speak up either. So not only do we have to invite, but we also have to guide and give some tools for which to partner. And that's exactly what we're going to talk about with these 3 tools. Now, we all know what SBAR is, right? So in provider-to-provider world, what does the S stand for? Situational, right? Background, assessment, and recommendation, right? So you'll notice that I've tweaked this slightly as a partnership tool for patients and families. So my vision for SBAR for patients is something that we can use in any area, probably most applicable to the ER and to clinic settings, right? So if we give our patients and families, let's just say a sheet of paper that looks like this, with some directions that say, please write down your blah, 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 right? What would be the benefit of having somebody write down their symptoms while they're waiting in the ER waiting room? Well, number one, hopefully it might occupy them for a little bit, because I don't know about you, but sometimes you wait a little bit, right? But also because it's not uncommon that, I'll just speak for myself, I get back into the room, the nurse comes in and says, or the doctor comes in and says, Tiffany, what brings you here tonight? And all of a sudden I have the white coat syndrome and I can't remember, right? I can remember some of my symptoms, but not all of them. And if you're trying to make a diagnosis, you probably want to know everything that's going on, right? So writing them down ahead of time will take care of that. Background, now that sounds like easy. You know, of course, for some people it is easy. If all you've ever had in your life is a broken arm, then that's a pretty quick list. But for someone like me who's been a patient since 1973, it might take me a minute to think about, what do you really need to know? That's why I said relevant background, right? What do I really need to tell this person about my medical history? That's going to take me a little bit of time to process and edit and whittle down, right? And then assessment. Well, I can't make an assessment. I'm not a healthcare provider. But I can provide a couple of pieces of information that might be helpful. One, have I ever felt this way before? If I have, what was it? What was the eventual diagnosis? And how did we treat it effectively? The other assessment that one of our ER docs likes to make is he says to the patient when they come in, what do you think is going on with you? Because if the patient has a headache and the doctor's thinking migraine and the patient's thinking brain tumor, then that's a really good place to start a conversation, right? And then finally, requests. This is similar to symptoms in the sense that it's pretty common for someone to do an intake, they leave the room, and that's when I remember that I'm a diabetic and I haven't eaten all day, and I need to run around the ER with my gown flapping, trying to find some graham crackers or something. So if I can write down, I need a blanket, I need some pain meds, I need some water, whatever the case may be, it all goes to the same goal. What goal do you think that is? Any guesses what I'm working for here? What do you feel you need now? So taking care of immediate needs. But SBAR for patients as a whole.
Getting good care.
Getting good care, right? So streamlining communication. And I think, as we all know in healthcare, time is gold, right? So when you come into a room and you say to a patient, what brings you here today, and they start in 1973, that's not streamlining your communication. So anything that we can do to make our communication concise and precise is going to help the patient and the provider. So that's the goal I have for this tool. Another tool, this is one of the best tools I can think of to walk that fine line between being effective and offensive. It's called CUSS. And I like it because if you're feeling frustrated, you may just remember the acronym CUSS, because you feel like cussing, right? So CUSS stands for concerned, uncomfortable, and scared. Now, in a provider-to-provider conversation, the S would be for safety. But I don't recommend patients and families use S for safety because I don't want them to use it improperly and then they've just lost credibility, right? So I changed the S to scared. So if I have something going on that's frustrating and I say to my physician, I am concerned, I am uncomfortable, and I am scared, to me, it's very similar, not that anybody here has ever been through this, but if anybody has ever gone to couples therapy, it's very similar, right? Because when we go into couples therapy, we're taught to speak to each other in a particular way. We say, I, right? We use I language. I think you're a jerk, right? No, that's not, I'm just kidding, that's not how it's. You say, when you say blank, I feel blank, right? Why do we use I language in couples therapy? What's the point? To keep the person who's listening from getting defensive. Remember the fine line between being effective and offensive as a patient advocate? If I, as a patient, say to you as a provider, I'm concerned about something, I'm uncomfortable about something, and I am scared. Is there anything in those 3 sentences that I have said that point a finger at you and say you're doing something wrong, what's wrong with you? No. But have I communicated my concerns effectively? Most likely. So this is a wonderful tool that we can give to patients and families when they want to communicate their concerns. Finally, this is called the patient safety call-out. Now, I don't know what you guys have here, but I know at Duke and UNC, they have badges or yellow cards on their badges that say, I need clarity. That's their call-out for safety. So if they happen to be in the OR and then somebody's going for the left leg and the person thinks it might be the right leg, then they hold up that card and it stops the line. So everybody in the room has to stop, listen to the concern, and address it, right? Now, I don't know that that's a great tool for patients and families because I need clarity. It makes you feel really British, and it probably is not, very natural or organic. So when I was in Tacoma, Washington, I saw them actually teaching patients that God admitted a patient-family call-out, and it was this. What does that mean? Time out. I love this tool. Number one, you taught it to me, right? So hopefully you won't be offended when I use it. Number two, it in itself is not very offensive, right? And number three, it's not medical mumbo jumbo. It's not medical jargon. This is something I've been doing ever since I've been playing Little League or whatever, right? And so it's something that feels very natural and Americana. So hopefully it's something that will feel natural for that patient and family to do. We've actually started using this in our Patient Family Advisory Council meetings as a way of trying to implement this tool in various aspects of care. So if we have somebody in the front of the room who's just using medical lingo, one acronym after another, then the council will do this. And that person will then go, oh, let me go backwards and talk about this in English, right? So wonderful tool, many applications. All right. So some of you might be thinking, well, that's really wonderful, Tiffany, but not everybody's going to be able to do that. And that's absolutely true. The way that I envision these tools and the way that I envision this engagement with partnership to decrease error is really more of a progression. It's almost like we have patients and families who are in elementary school learning things for the first time. I call those folks the one step at a time patient and family. Maybe they've never been in the healthcare system. Maybe they have cognitive impairment. Maybe they have literary issues. Whatever the case may be, literacy issues, whatever the case may be, we can still bring them into the partnership. And I'm going to talk more about that in a second. Then you have your next layer, your high school students, right? They might not be ready for SBAR, but maybe this is time to start asking them to track their own data. I track all my own pulmonary function tests and all my own BUN and creatinine lab results, so that when I'm watching them, when my doctors are watching them, and if I see something, I can bring it to their attention if there's something of concern. I also don't think it's okay to walk in the room and when someone says, what medications are you on, for that patient who's in high school to say, I take the pink one and the blue one, right? We need to have our patients and families become empowered enough to know what their meds are called and what they do and how they may interact, right? So that's the next layer of engagement. And then of course you have the PhD level patient and family who's engaging on that higher level with SBAR and CUS and things like that. My vision, my expectation for that level is it's probably going to be people who are more often in the healthcare system. So people with chronic illness are probably more likely to participate in that way because they are really looking for those avenues of partnership and good communication. So, we're going to talk about giving your patient a job. Again, I said that not every patient and family is going to be at that high level, but that doesn't mean they can't be a partner. So I'm going to read you, this is an example from Team Steps, and what I'm going to ask you to do after I read it is I'm going to ask you to have a quick conversation at your table about what job this individual could be given. So, Ed Johnson is a 41-year-old patient with a history of hypertension seen in the cardiology clinic for a follow-up after his recent admission to rule out a myocardial infarction. His vital signs are normal except for a BP of 170 over 110, and EKG shows NSR without evidence of ischemic changes. He states that he has been having episodic chest pain since his release, so the physician decides to repeat his cardiac enzymes. His CPK is 201 and troponin 1 level is pending. Mr. Johnson's pain resolves and he insists on going home. The troponin 1 level is still pending when Mr. Johnson is discharged with instructions to call the office the next day if he's having problems. Shortly after Mr. Johnson is discharged, the troponin 1 level of 0.22, where normal is 0.03, indicating a myocardial ischemia, is called into the nurse in the clinic. The nurse notifies the physician. No attempt is made to contact Mr. Johnson. Later, he's found unresponsive, having difficulty breathing. His friend calls 911, ambulance arrives, they find him apneic, and they can't detect a pulse. So when you do this exercise in Team Steps, the question is to the providers. What could have done better? And certainly that's a worthwhile conversation. But that's not the conversation I want you to have tonight. What I want you to think about is what job could have been given to Mr. Johnson that day so that he would be incorporated into the team and this outcome might have been different. Please talk amongst yourselves.